Dr. Chikaya mentioned in his talk that HIV is one of the most important comorbidities responsible for the deaths associated with TB. And many organizations, including the International Union as well as WHO, has called for integration of TB and HIV care to mitigate the impact of those dual infections. And to date, most people have cited the challenges of drugs, difficulties in diagnosis, and almost 10 years down the line, we are nowhere near reaching realizing that ideology of collaborations and complementary management of TB and HIV. Certainly not in high-burden countries, usually the BRICS countries, where TB and HIV is highest. What I'm going to do today, which is very different from the challenges cited previously, as Dr. Chikaya said, we don't only have to address the biomedical determinants, we also have to address the biosocial determinants. And I'm going to tell you about how we need to look at the distinct cultures, the distinct paradigms of TB and HIV, how different they are, and how we should consider marrying them. It would be great if we can create wealth to address that, but I'm less optimistic about that, so I'll leave that to Dr. Chikaya to do. My disclosures are that I received a donation of drugs from Bayer, not to do their study, but to do a TB clinical trial that was funded by the EDCTP, and we also have an extramural unit of the MRC. So the purpose of my talk is to bring to this largely HIV-friendly audience the issues surrounding TB, and to thank Kate Hankins for inviting me to do this presentation. And in this presentation, I would urge this HIV community to try and work with the TB community to bring TB up to where HIV is. And I will talk about the disparity in the investment in TB and HIV. The scientific advances in TB are inadequate to achieve WHO's goal of ending TB by 2035. I'm hopeful, but I'm not optimistic. And finally, I will share with you a little of the qualitative review that we've done in the contrasting between TB and HIV. So if you just look at the last 15 years, I see a pointer here. This one. Oh. Just in the last 15 years, this blue graph here is the total HIV studies in the last 15 years. And there were over 2,500. TB, there were about 350. I could almost stop my presentation there. However, there are about 10 clinical trials, specifically in MDR-TB at this point in time, mostly in the field. Some have been completed, but to date, given that TB is thousands of years old, there isn't a single published clinical trial on TB looking at a regimen for TB. Not a single published one. Last year at the Union, there was preliminary data presented on the STREAM trial. That is the first clinical trial in MDR-TB ever, and it has not been published yet. If you looked at the drugs that have either been developed or licensed for HIV and TB in the past 30 years. For HIV, given that HIV is about 30 years old, there are over 28 drugs. For TB, 2. Again, TB is thousands of years old. The last drug for TB was in 1958, rifampicin. And now we have 2 new drugs, maybe a third one. Funding. TB is critically underfunded. 10 years ago, for every $1 spent on HIV research, 5 US cents was spent on TB research. About 3 or 4 years ago, the Global Fund dispersed half of the budget on HIV and about 15% on TB. More recently, the NIH, the biggest funders of research, spent over $1 billion annually on TB and 3 times that amount on HIV. Maybe now with the association with TB and diabetes, we'll get a little bit of the diabetes money, and the association with TB and HIV will get a little bit of the HIV money. So now I'm going to move on to the more different part of my talk is to share some of the qualitative review of the contrasting cultures between TB and HIV. So we know that ART is empowering. And whilst the HIV programs emphasize and prioritize case detection and adherence to treatment, they place an equal emphasis on education, counseling, individualization, empowerment of patients. And in the words of one of our participants, part of the focused groups that we did, this participant said, "I always take my ARVs. It's because before you take ARVs, they tell us the tablets might do this, the tablets might do that, but if you don't take it on time, this is what might happen." So patients are educated and counseled on ARTs, and ART is empowering. Not so much in the TB program. And although this mindset is changing slowly, it is still infrequent in the TB program. The TB program focuses more on the proximal determinants of disease. The program model of care is based on detection, notification, and cure. So we need to change that mindset. ART is explained, not observed. And again, in the words of one of our participants, I can dodge. If I have a choice to dodge, I'll dodge the TB treatment. But ARVs, I never dodge them. So we know that one of the barriers to TB medication adherence, as you can see, specifically for MDR-TB, patients take about 10 different drug classes. So that's more than 10 drugs. That's besides the injectable. With HIV, we've got it down to a fine art. It's 3 drugs in 1 tablet. So of course, as scientists, we had to test this theory. Do patients adhere more or better to ART or to TB treatment? And in the study that we did, this was specifically XDR, TB, and HIV co-infected patients. And here you can see the blue line at the top. Adherence to ART was far better than adherence to XDR TB treatment, and overall adherence to dual therapy was not that great. We then went on to try and understand, why is this the case? And these are some of the quotes from patients. ARVs have never given me any problems since I started taking them. But when I was asked to take them with TB treatment, I started to have problems. It would be better if they explain about the tablets. No one tells us what is going on with it for that period of 2 years. Is it treatable or not? For TB, I was told that there are better ones. There are better TBs and there are worse TBs, referring to drug-sensitive TB and drug-resistant TB. You have a disease which can't be treated. You see yourself at the last stage. It's worse than HIV. I'm scared of it. I'm more scared of it than I am of HIV. So patients are poorly counseled about TB. And yet we never, ever hear about pre-test counseling for TB. And clearly there are benefits to this. It would provide an opportunity to discuss TB. It would discuss the risk of infection and how you can protect yourself. What are the implications of a negative or positive result? Think about strategies with coping. In fact, in the TB control programs, I'd be very surprised if anybody ever says to a patient with drug-sensitive TB, you have to take your treatment for at least 6 months, let alone for XDR or MDR TB, where you have to take it for between 9 months and 2 years. So let's talk a little bit about stigma. And it's traditionally been thought that it's more acutely experienced with HIV. Let there be no doubt in your mind that both these diseases are devastating and stigmatizing. And I don't know if Francois Fenter, I think I see him in the audience, but he didn't look up, so that can't be him. About 10 years ago, we shared a platform. And he said, if I had a choice between having HIV and TB, I would choose HIV. And I just could not understand. How could you say that? TB is potentially curable. And I will show you evidence of why we think that, in fact, it would be better to have HIV. Again, and I cite from one of our studies, we are used to HIV, but it's not easy to tell a person about XDR because they don't understand what XDR is. Most people understand about HIV, and it's easy to deal with. It's worse than HIV. I'm scared of it more than HIV. To me, HIV is not a problem. TB notification is incriminating, and it invokes fear. A patient described how this yellow car comes to her house. They put on gloves outside the house. They put on masks. Everybody in the community knows why that car is there. Her children run away. And she says she is tired of this. She is so afraid of the disease. So until recently, TB practitioners were using very incriminating terms like TB suspect. And only now is there an awareness. And in your minds, what images are conjured up when you talk about suspect? I'm sure this is what it is. Can you imagine for a minute within HIV programs referring to somebody as an HIV suspect? So we need to fight stigma, and we need to learn the lessons from HIV activism. In the HIV community, forces were rallied to challenge the stigmatization. And that didn't come from without. It was collective, it came from within the HIV communities. And if you think back historically, the gay community was already an established community. And the activism that changed and created tangible shifts in policy came from within the HIV community. In the TB community, this has not to date been adequately contested. The programmatic norms that reinforce TB stigma are beginning to emerge, and we have a few groups that are addressing this, but it's very sporadic, it's not sustained. And it's not, where's Mr. President? It's not sufficient to just create awareness about TB stigma. We need to create awareness from within. We need to have patient groups that have experienced TB, those that are affected, not just infected, but affected by TB, to share their struggles, their common problems, so that we can address stigma. And in that way, we can change these harmful practices. Some of you may recognize yourselves in this with HIV activisms. I'm sure there are many amongst you here. Specifically, Nelson Mandela, and some of you may recognize Zaki Ahmed as well. So there are very diverse approaches of HIV and TB care. In the HIV program, there's emphasis on confidentiality. Not so sure if we need to go down that route. Education and empowerment is driven by activism. They guard against stigma and discrimination. By no means is the HIV program perfect. The TB program is a very impersonal attitude. And at the beginning and even now, this impersonal attitude discouraged patients from disclosing their HIV status to TB providers. And many of you will remember the times where we would talk about hi-fi positive, retroviral positive, a virology number, as we shared information between healthcare givers. In HIV, there's a distinct sense of community. And again, I cite one of our participants. In the TB clinic, no one is taking care of you that much. If you are in the right place where you are, well, in the HIV clinic, you are taken care of. There is a difference. It's as if you're paying money to be there. They take care of you. At the TB clinic, I just go in and take my tablets. At the HIV clinic, I stay and talk. So it's not just about creating wealth. So if we look at TB and HIV control, the modus operandi in TB is a very well-regulated, top-down approach focusing on, again, the biomedical determinants of care. There's mandatory TB screening. The mindset of empowerment we mentioned is slowly emerging, but still infrequent. On the other hand, with HIV control, while there's a focus on case detection and adherence, there's equal attention to education. Voluntary testing versus routine testing. And we need to talk about that in terms of HIV exceptionalism. And it's driven by activism with that inherent mandate to safeguard individual rights, to mitigate stigma and discrimination. And there's almost none of that. In the HIV community, it's an inherent mandate. And all of you, many of you here, not all of you look like spring chickens. So you've evolved with the HIV epidemic. So in summary then, there are complete, distinct paradigms of TB and HIV care. The TB program and culture is rigid, it's impersonal. The HIV program is flexible, it's more holistic, and we need to look at ways of marrying those two programs. The focus, the HIV program can learn from TB. Do not be mistaken. We need some of that focused strategy of management in HIV. And we need to learn more of that holistic philosophy of care from the HIV program. And in conclusion then, we urge the HIV and TB programs to frame their collaboration in a more cohesive and complementary approach and address their distinct cultures. And in so doing, we might even have a chance. If we meet the socio-medical needs of patients, we may have a chance of improving outcomes, which is really what we want to do. And this is not airy-fairy. It must be realistic. There must be commensurate efforts for a more patient-sensitive approach. And all of this within the available financial and human assets which we have. Because the most important asset that we do actually have is the human asset. And finally then, in the words of Madiba, this is at the AIDS conference in 2004. The world has made defeating AIDS a top priority. This is a blessing, but TB remains ignored. If we're listening to this great man and we modeling ourselves on everything that he says politically, as a scientific community, as a care community, I urge you, let's listen to him and keep this in mind. And I would like to thank Kate for inviting me to have this opportunity to address you. And I'd also like to acknowledge some of our funders. Thank you.